We'll give you control.
Good.
Make.
Howard, do you want to see my first case before you do your fluoro?
Okay.
Looks like you already have control of the screen, Howard.
Oh, I do?
Yeah, just hit the little share button. It says you're the presenter, so.
Okay. Let me see what I have here.
It's like a little monitor screen logo. If it doesn't work, I can take it back and resend it to you.
Yeah, would you do that? I'm trying to see the share thing. Okay, David. I'll do that.
All right, you should get the little notification.
Good. All right. Here is the first interesting case.
So I don't see your screen yet.
All right. Let's see. Why not? No screen yet?
No, anyone else see Howard's screen?
Yes.
I do.
What is, okay. All right. I see it now.
Good. Okay. Here is a patient with a history of a urothelial cancer. I became aware of this case when I saw that a biopsy procedure had been done of a lesion in the right lower lung that you can see here. And this shows the location and the morphology and the attenuation characteristics of the lesion. You can see that internally there's a conspicuous area of low attenuation in that. And again, here is the biopsy procedure. So that was uneventful. And the biopsy was on the 18th. And here the patient, the next day, has a large amount of pleural fluid. So that's a substantial amount, and it has developed quickly after the procedure. There's no pneumothorax. That was aspirated. It was not bled. And now I will show you that over time, they drained the fluid, and you can see the chest tube there. And to make a relatively long story short, actually it wasn't that long, a diagnosis of, and I'll show you this, I'll bring this up, explosive pleuritis was made. So my clinical colleague shared this with me. This is from, not a journal, but it's an abstract from a presentation at a meeting describing a case of so-called explosive pleuritis. And you can see from here that there's a description of the development of the effusion, antibiotics were given, and the patient was ultimately diagnosed with an infection. As you can see here in this patient, that they did culture strep anginosus from the pleural fluid, no malignant cells, and that was one initial consideration that this was a metastasis. But I think it is interesting that the patient did have an area of low attenuation within. So putting everything together, this is certainly consistent with presumably a seeding of the pleural space during the aspiration procedure of bugs, and an interesting case of so-called explosive pleuritis. I'm not sure where that term came from. I don't know if this was the original description. I'd have to look to see if they have additional references, because they do. Actually, they do. There's a term called explosive pleuritis going all the way back to 1986, actually. And I hadn't encountered that personally before, but certainly, as in my case, that effusion was pretty explosive. So infection in the pleural space. Has anyone encountered that term before, clinical term, explosive pleuritis?
I have not, but I think this is a good reason why you shouldn't poke at a lung abscess unless as a last resort for this very reason. I find like the pulmonologists know, the thoracic surgeons know, but sometimes the general medicine services, if they get a patient with an abscess, they sometimes get requests, or I know our interventional people sometimes get requests to biopsy them or aspirate them, and they're always very hesitant. It's just with rare exception because of this exact possibility. You either get a bronchopleural fistula or you seed the pleura and get an empyema, or in this case, your explosive pleuritis, which is a great name, by the way.
Yeah.
That's a great name, but what does it mean other than empyema? I mean, because I think a lot of times we see patients that have pneumonias that present with empyema. We don't know how rapidly the pleural fluid developed anyway.
That's right. I think the issue is that if you have this explosive pleuritis, one should think about infection.
Yeah.
If one hasn't thought about it already as the etiology of it. Yeah. Rare entity develops within 24 hours, involves 90% of the affected hemithoraces, loculate early, and then this patient that did happen, streptococcal infections. Yeah. Okay, this next one is a trauma patient, a pedestrian hit by a car. This is the radiograph. I wouldn't diagnose anything in particular from the radiograph. We'll see in a moment that there is abnormality that is shown to be associated with the right hemidiaphragm, but I do not see a pneumothorax on this. So let me go straight to the CT. And I'm going to also bring up alongside it, let's see, I'll bring up the, okay, I'll bring this up here. So going down to the basal right hemithorax, we see that we have pleural air, and we also see that we have intra-abdominal air in the anterior portion of the upper abdomen. And correct me if I'm wrong about this, which should be the falciform ligament. And I'll give you a feel for what's there. Now I want to go way anterior here, and I'm going to click there to bring up on the coronal image that area, which is of course way anterior, and I'll bring that up. And there is clearly a small but a communication between the pleural space through the diaphragm to the upper and anterior abdomen. Here I'll give you a feel for what things look like in the sagittal dimension, just on the mediastinal window. On that side, one does wonder about maybe little bumps and maybe humps forming up here in relation to that. But the interesting finding particularly is the communication between the pleural space and the upper abdomen. Here is the op report showing the findings consistent with a rather large rupture of the anterior right hemidiaphragm, 12 centimeters in length, which they repaired. When they looked at it, they saw some lung through the defect, which didn't have any laceration. And they fixed that and actually found a little partial thickness left-sided diaphragm injury, which they fixed as well, but I don't see any findings of that on imaging. So a really interesting case of right hemidiaphragm rupture involving the anterior right hemidiaphragm and presenting in that fashion, which I think is really quite interesting. I don't think I recall a case in which I've diagnosed, well, first of all, it's unusual to get right hemidiaphragm injury, but the notion of actually getting a communication between the pleural space through the diaphragm anteriorly is quite unusual. Any comments about that? Ever seen anything quite like that?
Was there any upper abdominal injury?
Let's see, I think there was, let me just go to there was the abdominal CT up here of like the liver and so on.
Usually you see something, I mean, not always, but it's often associated with it from an increase of intra-abdominal pressure.
Yeah.
And I agree, it's a weird place for tear. And the other thing is you'd almost wonder, and I guess it didn't get to the pericardium because that central tendon is fused to the pericardium, but it looks like it took the pleura out instead.
Yeah, isn't that interesting, huh?
It's very strange.
Yeah,
That's cool.
yeah, really interesting op report, and they fixed that, a large tear. Wow. Yeah, I was quite surprised. It was diagnosed pre-op, obviously, which was kudos to our staff at night, which was great. Two very fast cases of anti-synthetase syndrome. So I'm going to just display the imaging data directly in the interest of time, with the clinical presentation. So here was a person that was apparently just doing fine. He developed a dyspnea and cough, and is often the case, patients are initially diagnosed with potentially a community-acquired pneumonia, treated with it. They don't necessarily get better, they may get worse. This patient actually became rather sick and ended up in the ICU for a time, and then eventually got some steroids prior to transfer here. So let's go back and look at February. And you can see the nature of these basal lung opacities, multifocal, multilobar, ground glass attenuating, consolidative, rather extensive in the lower lungs. And just for comparison, let's look to see what these look like in September. And we can see that clearly there are residual opacities. They're in the lung bases, within which we have bronchi, perhaps a little traction bronchiectasis, but certainly some architectural distortion. So this is the one with the EJ-glycyl-tRNA one, which is usually the anti-Jo one, but this was another one. And he was diagnosed on the basis of that and treated for that. So anti-synthetase syndrome. So usually we think that the pathology is likely foci of organizing pneumonia and or a cellular NSIP. And certainly no surprise that it's starting to heal, perhaps with some residual scarring, and time will tell what happens here. And the last patient with what turned out to be Jo 1 is this patient. And I'll bring up the history alongside to see the evolution of that. But a CT-PA was done at some point. This is no PE, but basal lung opacities, confluent, consolidative opacities involving multiple segments of the lower lungs at that time. And here is one later on showing still a lot of disease. Now we have the ground glass opacity, perhaps with architectural distortion and evolving bronchiectasis within, but also some residual and some new opacities in the lungs. So here you can see the patient presented again with the respiratory illness, then to develop some skin changes. One person wondered whether some of the skin changes were, if I see it somewhere here, which could have been mechanics hands, perhaps. Did develop findings of muscle weakness. I think had an MRI here. Yep, MRI here, which showed some findings consistent with a myositis. So again, anti-synthetase syndrome presenting like that initially, not surprisingly, as possible pneumonia, and treated with steroids and now rituximab. So two patients with findings very consistent with anti-synthetase syndrome. Okay, Jeff, those are mine for this week.
All right, thank you. Who'd like to go next? Do you want to, David, show your diaphragm case, or you for Howard if he has to go?
Yeah, indeed. So I hope people can see two radiographs here. This is a heart transplant person. The radiograph on your right was before the transplant. At this point, there's already been surgery with 2 valves in place and a defibrillator in place. And people who've had previous heart surgery, often it's an LVAD, on their way to transplant, have a higher rate of complication that involves the diaphragm. So I think that previous surgery creates enough scarring that when they try to do a transplant and remove the heart, they end up having the phrenic nerve maybe encased in scar and tearing. So this person is short of breath now. This is a recent radiograph, short of breath after this heart transplant, unable to lie flat, which is very provocative. Low lung volume on both sides. So the question was, could this be bilateral hemidiaphragm paralysis following heart transplant? Person had a CT scan at the time, or around the time of the previous surgery, but before the transplant, it showed normal cruise thickness on both sides. I don't think I need to show that. So everything looked good. We don't have a subsequent CT. So we were asked to do a sniff test, a diaphragm fluoro, and we're always eager to go along with that. So let me show you two parts of the sniff test. So I start out by having the patient standing, and I will do an AP view and then a lateral view. I'll have the patient breathe deeply, and I'll have the patient sniff. And then after doing that, I return the patient to AP view standing, and I will watch the person take 2 deep breaths standing, and then I'll tilt the table back 45 degrees. I'll watch 2 deep breaths, and I'll tilt the patient all the way supine and do 2 deep breaths. So let me show you the standing version here as this person breathes, standing up here. And you can see that as the person takes in a breath, the diaphragm descends about almost 1 rib interspace. So I consider 1 rib interspace normal, and this one is maybe half or 2/3 of a rib interspace. And sometimes it approaches a rib interspace. So it's not that abnormal. And you can see that as the diaphragm goes down, the anterior ribs go up. So we have this opposing motion. Anterior ribs going up expands the thorax from the front to the back. And as the diaphragm goes down, that expands the thorax top to bottom. So the person is able to get some reasonable respiratory excursion here. It's not great, but it sure doesn't look paralyzed. Then I tilted the patient down to 45 degrees and then eventually to supine. And this is the supine view now, when the person takes in a series of deep breaths. And you can see that there's now almost no respiratory motion here. There's almost no motion of the diaphragm. And if we actually look at the motion of the diaphragm, we see that the diaphragm, if you look at the right hemidiaphragm, it actually goes up when the anterior ribs are going up. So it's being dragged upward by the anterior ribs. There is no active motion of the right hemidiaphragm or the left hemidiaphragm here. So we have almost no excursion, and we have excursion that's actually paradoxical. It's moving, the diaphragm is going up with the anterior ribs going up rather than opposing them. So this person's diaphragm is paralyzed on both sides, or at least very, very weak. So how do we explain this almost normal degree of excursion with the patient standing? And it turns out this is all abdominal breathing. When I asked the person to take in a deep breath, it turns out the person has had his abdominal muscles tense. He's actually pushed his diaphragm up by tightening his abdominal muscles. And then when I ask him to take in a breath, he relaxes his abdominal muscle, and the diaphragm is actually passively falling here. So what looks like propelled excursion, active excursion of the diaphragm, is actually just passive motion caused by this abdominal breathing. So how do you distinguish that? Because the cases where you blow by the paralysis, when it's bilateral paralysis, the most severe diaphragm dysfunction is the easiest to miss. You have to do the supine view to defeat this abdominal breathing and then show that the diaphragm itself is not moving actively, it's just passively being dragged around. So the diaphragm is moving passively here in response to abdominal muscle contraction and relaxation. Here we defeat that by having the person supine. This guy got very dyspneic when he was supine, and he has a paralyzed hemidiaphragm bilaterally. So it's very important, especially when there is the question of bilateral paralysis, to include supine views and not rely on upright views. Yeah, I have come close to missing this. As a matter of fact, I did miss it in the early days. And so I always include the partially recumbent and then the fully supine views as part of my diaphragm fluoro, especially when there's a question of bilateral paralysis. So if somebody is dyspneic lying in bed, they can't go supine, or they can't tolerate wading in water that covers their abdomen and chest, so that's called dyspnea on immersion, then you have a strong suspicion that you're dealing with bilateral paralysis. And the standing views are not going to bring that out. You have to do the supine view. Okay, well, I'm
David,
glad to have the opportunity to bash you guys about that. What were you going to say, Howard?
Oh, sorry. One thing I've read too, and you sort of used the word abdominal breathing, is that some people say that on expiration, the patients actively contract the anterior abdominal muscles, driving the diaphragm upwards.
Right.
And then the relaxation of those muscles allows the diaphragm to come down. And that pattern of active exhalation is not easy to do when the patient is recumbent, right?
Yeah, recumbency defeats that, but that is the abdominal breathing we're talking about. So the person is walking around, you know, instead of having a relaxed abdomen, this person is actually tensing the abdomen, and then on the command to take in a breath, he relaxes the abdomen. But you and I don't walk around with our abdomen tense, but these people, they do that because they rely on that abdominal muscle to do their breathing. So they tense it, that creates expiration. When you ask them to inhale, they relax it, and that creates inspiration by letting the diaphragm fall.
The other thing that I try to do, and I usually have someone help me do this, is to examine the patient, not fluoroscopically, of course, but for thoraco-abdominal paradox. So when they breathe in, the anterior abdominal wall should pouch outwards.
Right.
The anterior abdominal wall goes inward, and that's just a visual observation of the anterior abdominal wall. So you can have an observer call in, out, so that you know, and they judge in and out by virtue of the way the patient's chest is moving and the ribs. When you know what's in and what's out, you can see whether the abdominal wall is moving inward, which would be thoraco-abdominal paradox. And the times I've tried that, you know, you need someone to help you with that.
Got it. Okay.
It's very interesting.
Then I'd like to show you this elderly woman who has been on treatment for SLE for decades and decades with some immune suppression. She showed up with a mass here in her right apex. This is from just a couple of, about 2 weeks ago, and she has some rib destruction as part of this mass. And it was assumed first that this was a lung cancer, and she got a biopsy which did not show any malignant cells, but did show some acid-fast organisms. So at that point, the consideration was this tuberculosis. Now, this is a recent exam, and you can see a lot of rib destruction at this point. If we back up to this previous exam from outside hospital last month, you can see there's not as much rib destruction at this point, and there's not as big a mass as we're seeing currently. There was a CT scan, and this is outside CT, and you can see that there is this big mass that invades the chest wall and is destroying bone. So it's eroding ribs and so forth, and it's only gotten worse since this exam. And elsewhere, there's not a lot. So they recovered acid-fast organisms, and it was not MTB. And then they thought it was nocardia. There were filamentous sorts of things. And finally, the PCR revealed that this is an atypical mycobacterial infection. This is Mycobacterium xenopi, Xenopi, which when it hits people, it's usually a compromised host, and she qualifies as a compromised host by her immune suppression for her lupus. Also seems to have a little bit of esophageal dysmotility here, a lot of material in her esophagus and dilation farther down. So this sort of thing would predispose to aspiration, but this is not an aspiration zone lesion here. So Mycobacterium xenopi, I don't think I've ever seen a case of this before, but dramatic lung and chest wall involvement. So organisms that can do this include tuberculosis, nocardia, actinomyces are the famous ones. Other fungi are on the list for lesions that involve lung and spread into chest wall. So xenopi, and here's what it looked like on PET. It's a very hot lesion with a necrotic center. And then this man had a fairly normal radiograph. At this point, he's an AML patient. This is his old radiograph, and then this is his more recent radiograph with a compact, probably fungal infection at this location here. You can see it's in the lingula, and here's what it looks like on CT. It's got a little bit of a necrotic center to it, so it looks like a very thick-walled bird's nest if you're so inclined. So it really looks like a nice example of mucor. It seems to be in contact with the mediastinum, and there's pericardial stuff here, so it may be spreading into pericardium. So, and there's an accompanying pleural effusion surrounding possibly hemorrhage if there's angioinvasive fungus here. So this lesion was biopsied, and the presumption was mucor, that this was going to be some sort of a zygomycete, and it turns out instead to be Naganishia, and they gave 3 possible species of Naganishia, which I have never heard of before. And so I looked up a little article about this, and here's an article that mentions this as a Cryptococcus species. So you can see that it's Cryptococcus, and now it's called Naganishia. Albidus was one of the things, or albedo similaris were possible species names in this. I don't think they really tried to distinguish the species. So it's not clear to me, and I've asked my infectious disease colleague to instruct me about this, whether Naganishia is an alternative name for Cryptococcus. Perhaps this was formerly considered Cryptococcus, or maybe it's Cryptococcus and it's a variant Naganishia or something like that, but they're not calling it variant in this nomenclature at least. But I could not find any examples of Naganishia albidus lung infections out there, but we have to presume that this is like a cryptococcal-like organism, and Cryptococcus likes to attack compromised hosts, and an AML patient is definitely a setup for that sort of thing. I think I would have been very suspicious about mucor, given that central necrosis, that bird's nestiness, and the possibility of invasion of the mediastinum along with it. So has anybody heard of Naganishia before? I'll try to give you more information if my infectious disease colleague's instruction arrives on time.
That's a new one for me.
No, sure.
Nope.
And evidently the fellow is feeling better on treatment that I think is probably Cryptococcus appropriate treatment. I'll get the name of the antibiotic.
Ivermectin.
Ivermectin's good for everything. You know, since I've been taking it, I've not had a single instance of COVID. So
Yeah.
Okay, guys, thank you.
Thanks,
Thank
David.
you.
All right, who wants to go next?
I can go since I didn't show any last week.
Sounds like a plan. There we go.
All right, should see my database screen and a radiograph here. And this is one of the better examples of this I've seen in a while, and I'll let you look at it for a moment. I think it's just bread and butter, and especially with residents, I think always beat into their minds the appearance of left upper lobe atelectasis. In this case, you can see there's definitely volume loss on the left side. Notice also the spacing and the paucity of vessels relative to the right side. And then you can see that you have loss of the descending thoracic aortic interface, as well as a little loss of the medial aspect of the diaphragm, not much, but there's this sail-like configuration here. It's awfully thin at this point, and then you have kind of the flat waist sign, or the flattening of the left left heart borders from mediastinal rotation, and all of this, you know, fits with left lower lobe atelectasis. Now the lateral view, this is done at the same time. I don't really see anything here that would lead me, maybe a little bit of loss of the posterior left hemidiaphragm, but occasionally you see a little bit of increased attenuation along the spine. Also, you know, maybe you guys see something on the lateral more than I do, but I think the left main upper lobe continuum is right here. I was trying to look, maybe, you know, something in here, because you should see, I think this is intermediate stem line from the right side, and I don't know, but do you guys see anything that you would say is a mass on the left side of airways?
Not me.
But here it is, and you'll see why, I think, just because it's so deep into the left lower lobe bronchus. And this is actually after a little bit of debridement. Maybe this is the one that has it, shows the larger. Yeah, so this is the original one. And so you can see why you don't see anything on the lateral, because the left main upper lobe continuum is coming out straight laterally here. So that's what you're seeing. But this was a carcinoid tumor in here. This is all some dystrophic calcification. I don't know how much of this is tumor, maybe a little bit of adjacent mucus or secretions, but they've debulked it some, and you can just see this must be there for I don't know how long, but just chronic real collapse of the left lower lobe and a lot of volume loss. Just a really good example of left lower lobe collapse on a radiograph.
And it's one of those ironic things that the worse it is, the more collapse there is, the harder it is to see, because it can disappear altogether. This one is visible on the frontal, but sometimes the degree of collapse is so great that you don't even see it on the frontal.
Yeah, it's almost just straight up and down like the aortic interface.
Yeah.
All right, now this is one that I think is really interesting and a little scary, but this is a patient who underwent a lung cancer screening CT just before the onset of COVID and has this lesion down here. This nodule has somewhat lobulated margins, and it has a lot of what I would say is it's calcium in it, whether it's bone or just calcification, I'm not sure. Obviously, I've let in that this is a little bit scary, but you know, you might be inclined to say this could be a hamartoma. It doesn't really look like a granuloma on first pass, but I don't know. What would you guys do in terms of follow-up of this if you just saw this right off the bat?
Can you just show the calcium a little, like change the window a little bit?
I can show it on bone windows.
It looks popcorny, but at the same time, it looks a little chondroidy.
Well,
yeah, I would discount. I would discount hamartoma in this case because it's lobulated. Hamartomas are very nice spheres. They don't have this lobulation sort of pushing out, sort of margination, and the calcium. A lot of that calcium is very faint. The calcium is usually very crisp. So, you know, I think this is an adenocarcinoma. It might be an adenocarcinoma growing on a granuloma, so kind of a scar carcinoma sort of thing.
Yeah, exactly, like a collision tumor consuming it.
Yeah.
Well,
it might be dystrophic. It might be dystrophic calcification in a carcinoma. It's also, the lesion is also inhomogeneous. Besides the calcification, it's sort of blotchy, lower attenuation in it.
Yeah. Well, fortunately, it made it easier when there was a prior from 3 years or 2.5 years before that, and there was nothing there. I'm discounting this little thing. I mean, maybe that's the start of what this is, but this was all new. It was not a treated cancer at this point. This was biopsied, and it actually turned out to be small cell carcinoma. And it was a limited stage small cell. There were no nodes. There was nothing. They elected to treat systemically, even though it was limited stage small cell. And then here's the follow-up this year. And I saw this right after Howard had showed that case. Now it's almost completely calcified. well, actually, I don't know. Maybe they just gave, well, I know they gave radiation too. Maybe they gave systemic therapy as well, but they did not resect it. But you can see the radiation related lung injury and fibrosis developing around it. But this is what it's left with. But yeah, I think, you know, and Jeff, your comment on popcorn calcification, you know, we've all seen lots of cases like of metastases
Right.
from, you know, from chondrosarcomas or whatever. You know, I never count popcorn calcification in the lung as a definitively benign pattern of calcification. But this is just driving home the point that,
Yeah.
you know, especially when something's new, and David's point too, the fact that it's lobulated doesn't necessarily, you know, equate to
It's
being
soggy
benign
popcorn
either.
because the
Yeah.
amorphous calcium. That's a tough one. I mean, it had enough unusual things. I mean, I probably would have followed it. I don't think I would have jumped on a biopsy. If it were small cell, it should declare itself rather quickly.
Yeah.
But I wonder if it was a collision lesion because, I mean, small cells grow so fast, I don't think they have time to calcify. And they don't.
Yeah, well, I mean,
who knows?
the fact that we had the prior from just over 2 years before, and there was nothing there calcified, you know, you would have had to have had a quick granulomatous infection and then calcify. So I don't know. All right, come on, close. This is a quick one that we saw this week, and it's a fun one though. Let me make sure. This is a patient that underwent a lung transplant about a month ago, so late July, for emphysema. You can see he still has the skin staples from their clamshell sternotomy. Had a bronch after this radiograph, and then the next day was in rehab and was developing chest pain and just generalized discomfort and shortness of breath. And you can see here that they have bilateral pneumothoraces, fairly sizable. And you know, Howard talked about explosive pleuritis. This is another pleural disease, not explosive, but here we can see, and no surprise, they put in one chest tube in this patient on the left, and both the pneumothoraces have resolved after that. So of course, this patient does have acquired buffalo chest physiology or anatomy with connecting or communicating pleural spaces. I don't have a CT in this case, but you know, oftentimes when we get CTs in the post-lung transplant period, you see the communication of the pleural spaces. So the behavior of this with both of them reappearing and then decreasing with one chest tube was typical of a buffalo chest. And you know, much like one of my residents actually brought this up because we were discussing bovine arches and how that's a misnomer, that the human arch with two vessels isn't actually a cow's arch. We got to searching for the origins of buffalo chest, and this is actually a kind of entertaining article that's in press right now in Chest. It was just released online in June, and these people went to great lengths to kind of find out if this anecdote was true about a single arrow being able to kill buffalo. And it ended up I think they're Dutch, but they ended up coming to the United States and performing autopsies on a series of doing autopsies on bison at a meatpacking plant. And they found there were interpleural communications in 4 of the 8 that they looked at. So it's not all buffalo that have communications between them, but they did find them in 4 of 8, which I thought was pretty entertaining. And it all stems from one article in 1984 from a personal communication with a veterinarian in Arizona who told the anecdote. So it's entertaining if you want to read it. And I'll show one more here. This is a
Travis, can you send that article?
Sure.
I think that's beautiful.
I can put a link in the text here, and I can email it to you as well.
Thank you.
And then this last case, this is a nice interstitial lung disease case. And you can see this is a 39-year-old woman, and this is a few years ago. She's been transplanted since then. And I think in somebody this young, you know, when you see stuff like this, it's not unsurprising to see a patient that has an unclassifiable pattern of fibrosis. In this case, this is just diffuse reticulation, some ground glass, maybe some traction. It really involves all segments of all lobes, and we'll come back to this finding right here in a moment. And the interesting thing in her case, and I know a lot of times My residents and fellows struggle and spend a lot of time trying to classify these. But when it's like this, it's often easiest to just save time and throw your hands up in the air and say, don't know what's going on here. But one of the things to think about in a young patient like this would be some sort of familial disease in addition to connective tissue disease. And so a couple years later, she gets follow-up, and this is actually before transplant. And you can see it's worsened. She has progressive decline in function, worsening reticulation, contraction, and this bubbly thing has grown. So the possibility of lung cancer was raised. She was young, they did a segmentectomy. This was an adenocarcinoma, but all of her nodes were negative and everything else. And so she ended up being transplanted and is 5 years out, disease-free from bilateral lung transplant. And as of right now, she's familial pulmonary fibrosis with an unspecified mutation that hasn't been identified yet. And what was interesting in her is her grandfather had fibrosis in his 70s, her father in his 50s, and her in her 30s. So she's showing, her family tree is showing signs of genetic anticipation, which is not uncommon, where each successive generation develops fibrosis at an earlier age. So that's one of the hallmarks of familial fibrosis. But the usual no, go ahead, Jeff.
I was gonna say, is that more common with the telomerase mutations than like some of the protein deficiencies?
Yeah, exactly. I think so. Certainly it's seen with the telomere mutations. And as of now, I was looking to see if they did telomere lengths in her. I couldn't find anything because some of her workup was done elsewhere. But this is a look that we see in a substantial minority of familial cases, just of unclassifiable fibrosis like this.
What did you call the acceleration?
Genetic anticipation.
Genetic anticipation. I like it.
Yeah. So in succeeding generations, it occurs earlier. And as Jeff said, yeah, that's typical of telomere shortening mutations. All right, I'll stop there.
Okay, we got Brian and Seth.
Oh, do you want me to throw? I could throw 3 quick ones up.
Yeah, go ahead.
Okay, this is just I showed one of these a while back. It's just a nice example of, whoops. Does this have the lateral on it? No, it doesn't have the lateral. So here, the frontal, you can kind of make out something in the subchronal space, but I think, if you're shooting through films, you might go by it very quickly. But on the lateral, you can see that there's kind of something here, and maybe even a layering collection of something in the subchronal space. And this is just, I showed one a couple of years ago, but this is another extraordinarily hyper-dense bronchogenic cyst. So you can even say
Is there a little air in that one too?
I think there may be. It was right by the tracheal bifurcation, so let me see.
Or is it, no, I guess it's just.
Maybe, oh, there's some, maybe, is that fat?
I was gonna say, is that lipid?
I don't know. I mean, it kind of looks like it, but there's
cool.
layering milk of calcium. I mean, I guess, I can't imagine it would be a teratoma, but there may be some, you're right, there may be a little bit of lipid there. That's odd.
I think it's floating.
Yeah, I think it's floating too. So.
Oh, wait a minute, it's CT, so it's not floating. Take it
Yeah.
back.
But you're right, it does look like there's something. I can't tell if that's along in the cyst or along the top portion. Anyways, maybe it is a hamartoma. I thought it was, I mean, not a hamartoma, a teratoma, but I really don't think so. I mean, it's got to be a bronchogenic cyst with layering milk calcium. I guess it's possible. But they're going to take it out. We'll find out one way or another. There's another little kind of thing here too. So maybe, you know what? I didn't read this study. It was kind of shown to me. I didn't really look at it that closely, but yeah. I don't know if that's really going to change anything in terms of surgical approach, but I'll let them know. Interesting. I don't think, has anyone ever seen a teratoma in this location?
Nope.
Yeah, I mean, I've seen tons of teratomas. I've never seen one in that perfect location. So probably just an atypical bronchogenic cyst.
Agreed.
I think it's a cyst, and I think it's fluid filled because it's conforming to the mediastinal contours there. It's not
Oh, yeah,
pushed
it's fluid filled. It's proteinaceous fluid, 100%, 100% proteinaceous fluid. Absolutely. This case, what was, oh, this is just a nice example of, remembering that HIV is commonly seen with HHV8 superinfection or co-infection. And HHV8, as we know, is associated not just with these, very large lymph nodes, which happen to be secondary to multicentric Castleman disease, which we know we see in HIV, but also I'll show this one doesn't have the best lung imaging because he's breathing, but also associated with Kaposis or Kaposis, I don't know what people how they would like to pronounce it these days. Also associated with, or I think some people say Kaposi's sarcoma. So this is a patient with both pulmonary Kaposis with nice flame-shaped things in the lungs, and then bulky, this is a non-con, so you can't see the lymphadenopathy, bulky lymphadenopathy due to multicentric Castleman disease, which are both HHV8 related. And we also know that he had one of these nodes started getting really nasty and underwent biopsy, and one of them transformed into as they usually do, an aggressive lymphoma. So anyways, just a kind of nice showing of those two existing together and that they're associated with the same viral infection. And go back to this. This is just a sad case of something I've shown that I see a fair amount of here. Of course, called a PE on the outside. You can see the big soft tissue mass in the pulmonary valve, and then extending along the wall kind of has a sausage there, some soft tissue all along. And it really is amazing. The surgeons will say that when they go in there and take even the stuff out here that we don't really see, you can see a little bit of tumor here, but even the stuff out here, and even if it's unilateral, they say even when they do the intimal resection on the other side, because they send them here for endarterectomies, still out for debate how much it improves survival. I don't think there's a good paper showing that it actually does. But this is post-op. They actually damaged the right pulmonary artery, and that's not post-op because that's the wrong case. I was like, that looks much better than I thought it would. Let's see here. So this is post-op, and they damaged the right pulmonary artery, and so a lot of this stuff around, they said they kind of, the tumor is so invaded they actually had to cut it out and rebuild the pulmonary artery. Still some soft tissue here, and they know they never get all this stuff out. And this is post-op, and then basically we had another study the other day, and then they got a cardiac CT, and you can see now it's better seen on it's better seen on the delay. Figure out how to do this. So you can see that now there's all this soft tissue in the region of the pulmonary valve where they replaced the pulmonary valve. And not only that, there's all this soft tissue growing along the RPA into the pericardium, into the superior pericardial recess and around the SVC. And just to show some kind of quick videos of this, let's see, can I get this to open in any sort of way? So you can see that it's actually pushing the valve up. The valve was seated over here by the annulus, is actually displacing the valve, and now there's just tumor growing all throughout the RVOT. And this is, 3 months or 4 months after surgery, maybe 5 months after surgery. Here you can see the tumor growing along the RPA. So unfortunately, common thing we see here when they take these patients for sarcoma resection.
What was the histology? Was it?
That's a good question. let's see here. Intimal sarcoma, high mitotic rates involving both pulmonary arteries. I don't know, there's like this whole long thing. They just say basically intimal sarcoma. I'm sure somewhere there's a huge report. I'm sure somewhere buried in here there's an actual better, because intimal sarcoma doesn't mean anything because they're all pretty much intimal sarcomas. Usually they're the ones we have here, most of them are called poorly differentiated, for better or for worse. But all right, Jeff, those are just quickly my cases.
Oh, thanks. Brian, did you have any cases?
Can you guys hear me?
Yeah.
I can show one real quick.
Okay, I can go next week, it's fine.
This is a young woman with a congenital muscular dystrophy who had these spinal rods placed as a child, and now she's in her 20s. You can see presented about a year ago with a large right pneumothorax. Got a CT a few days later, and what you can see on the CT, there's a large right pneumothorax, and there's this area of kind of perhaps scarring or atelectasis involving the apical right upper lobe, and a little bit there anteriorly involving the right middle lobe, and then a chest tube, and things look pretty good. Here's a sagittal from that, and you can see this screw up here at the top there are several screws that are kind of going beyond the vertebral bodies, but this one in particular, you can see on the axial pretty nicely, is surrounded by air pretty compellingly, as opposed to this one, which is still perhaps covered by a thin layer of parietal pleura. And so she presented a few more times over the next couple of years with recurrent pneumothoraces. And ultimately, the surgeon took her to the operating room and did a pleuritis. And he said that when he was in the OR, what he found was that several of the screws were protruding beyond the kind of indenting the pleural space. But this topmost one, you could actually see the metal from it in the lungs, and that this part of the right upper lobe was very scarred and inflamed with some cystic and bullous changes. And here's a 3D reconstruction showing that topmost screw also. So yeah, this is I'm not sure, they're going to try and revise this, but presumptive recurrent pneumothoraces from a paraspinal pedicle screw that's impinging into the right pleural space.
That is impressive.
Cool, that's it.
All right, thanks. All right, I can probably show one or two then. Let's see. All right, you guys should see a chest CT. Yes, so this is a patient who has medullary thyroid carcinoma and has had metastases known and documented in the past, and long-standing disease. So this is about 5 years ago, had an infection at the time. That's what a lot of this stuff is up here. But what I want to point out are these small cysts in the lung, and you'll see that they're very small, perivascular, thin walls, no real distribution, a couple more here and there, but had these small cysts. There's another one right there in the left upper lobe. And I came across this one here. So we're following up, and you'll see that the cysts are more conspicuous. There's probably a few more of them. They're definitely bigger. And they kind of look like LIP type cysts, amyloid cysts, or light chain, in that they're perivascular, very smooth. It doesn't have the distribution of Lamb, and that it's polycystic disease. And I remember in this conference that Travis had showed a case, I think Howard may have as well, of a case of medullary thyroid carcinoma with cysts. And then there was a paper that was sent with that, and that talks about how the calcitonin, which of course these tumors secrete, can form amyloid fibrils. And then of course we know amyloid deposition in the lung can cause cysts through the disruption of the normal metabolism. You get the matrix metalloproteinases and stuff. So I made the presumption that these cysts are due to amyloid from the calcitonin from the medullary thyroid carcinoma. But I wouldn't have put the 2 and 2 together had I not seen it before in this webinar. So that was kind of fun. I don't have any proof, but the patient doesn't have Sjogren's syndrome or any other connective tissue disease. So I think it's a good assumption. All right, and then this is a very fascinating case we reviewed in our ILD conference. So this is a youngest patient who was short of breath and had this chest radiograph. And as an outpatient, you can see there's striking peripheral sparing and this sort of diffuse lung disease that sort of has this lacy appearance in some areas. And then this was the CT scan, and we have a lot of ground glass and consolidation. And in those areas of density are these lucent cystic spaces. And if you look up here, there's a little bit of emphysema, but as we go down, the holes in the lung seem to be confined to areas of abnormal lung. There are a few areas that are maybe a little crazy paving-like, but it's very, very dense. No effusions, no lymphadenopathy, and that peripheral sparing sort of persists throughout. This was done elsewhere. They did a bronchoscopy and the airways looked normal. And then so they did a transbronchial biopsy. And the pathologist initially didn't see a lot, just a little bit of organizing pneumonia and some chronic inflammation. But when he looked at the CT scan in consultation with us, clearly there wasn't something right with the biopsy. So he got some deeper cuts and found some pink stuff, but it was extra-alveolar, and did some more stains, but was pretty convinced this was alveolar proteinosis based on a transbronchial biopsy, but was a little troubled because the CT wasn't very typical. I mean, it's not incompatible, but it's not that classic geographic crazy paving. It's much more consolidative, and I can't explain all the holes in it. I mean, definitely a little crazy paving there. So they sent the GM-CSF antibody off, which is many of these patients had, like 90% and it was positive. So we after discussion and reviewing of the pathology, we came to the conclusion that this is indeed alveolar proteinosis from anti-GM-CSF antibodies. It's just a very atypical appearance. We did have a pediatric pulmonologist present, and he said he's seen this pattern in children. It's not that common, but he has seen it with this denser consolidation. And I haven't seen many cases that vary from the typical crazy paving geographic. And I don't know how to explain these holes in the lung, and the pathologist didn't really have much to say. It was a transbronchial biopsy. So I'm curious if anyone else has seen anything like this.
I think they're developing fibrosis. And we had a case I just saw yesterday, and it's a patient who was transplanted for fibrosis secondary to alveolar proteinosis, and now they have recurrence of their alveolar proteinosis.
Oh, wow.
And I'll have to find it. And I showed a case at Emory long time ago, like first year of our webinar, of a young patient pediatric patient who had fibrosis. And that was one that didn't look quite like this, but on surgical lung biopsy was chronic alveolar proteinosis as well. So I wonder if they're just developing some fibrosis.
Yeah, it's hard to know. I mean, this is the initial workup. So they're going to do what they're going to do is they're going to attempt a whole lung lavage, start with about 1 liter. And if the patient tolerates it with single lung ventilation, they'll proceed with the lavage. Because our debate was also, do we treat with GM-CSF? Do we treat with lavage? Lavage is better. The GM-CSFs can be inhaled or injected, and the literature is kind of iffy on which one's better. So that's the plan. But the bronchoscopist was there as well and was rather surprised that the airways were so normal. So it's just a very atypical case, but it's good. I think what sealed it for all of us was the autoantibody. And it was good on the pathologist's part to dig a little deeper, because he was just, otherwise it was just a little bit of organizing pneumonia and some inflammation. There wasn't really a lot, and it was a good biopsy. I don't have the slides, but there wasn't a lot going on. All right, what is the hour? So I'll stop there, but great cases, everyone, and take care, and I'll talk to you next week.
Thanks, everyone.